Welcome everyone. I'm just going to give people time to get in. We've got 220 signed up today, so it's going to be a little bit busy whilst everyone joins. Just bear with us. Warm welcome everyone to the Designing Better Health Services, Leading with People and Neighbourhoods, where today we will explore how meaningful patient and public involvement, co-production and neighbourhood-focused approaches are really transforming health and care design across Yorkshire and Humber. Today's session will bring together leaders, clinicians, innovators and people with lived experience to share real regional examples, practical tools and insights to help embed people-centred decision-making in health service design. We've got 220 people signed up to this webinar today, so whilst I would love to kick off at 1 p.m, we're just going to let people trickle in. We're currently on 46. We'll just give it a couple of minutes and then I'll kick off into welcome and housekeeping. I hope you're all well today. The sun is shining where I am in Robert Town. Okay, I'm going to move on to welcome and housekeeping. So please feel free to introduce yourself, pop your name and your role in the chat. And please do keep your microphones muted throughout the sessions. Your cameras will be turned off automatically unless you are one of our presented or are invited to speak. And this will really help reduce bandwidth issues and keep the session hopefully running smoothly. Please use the chat function to share your comments or your reflections. We're keen that this is a space for collaboration. We do have a couple of slots for questions and answers. We've dedicated some time today to answer them in person. For those that we can answer today, we will be pulling together a full question and answer document and we'll be sending that round after the webinar. This session is being recorded. The slides, resources and the Q&A will be shared afterwards, and we will be probably publishing the recording somewhere for other people to access. Okay, it's 3 minutes past looking at my phone, and I know we've got a trickle of people coming in, but I think I'll move on to my bit now. So I'm Adele Bunch, I'm Head of Portfolio here at Health Innovation Yorkshire and Humber, and I lead on health inequalities and patient involvement. And a big thank you to everyone who has joined today. I know this is somewhat spanning over lunchtime. Very quickly, let me just tell you about who we are and what we do. So Health Innovation Yorkshire and Humber, we are one of 15 health innovation networks across England. We are commissioned by the NHS England and the Office of Life Sciences, and we run a suite of national programme activity, and we also work locally, often commissioned to support innovation, adoption and research. In Health Innovation Yorkshire and Humber, we tackle national programmes in locally tailored ways and in partnership with our local systems, patients, researchers, academia, so that everybody benefits from that innovation. But as a network, we use our collective voice to take locally proven ideas to spread them across health and care at scale. So each health innovation network has an innovation triage pipeline where we capture new innovations via a triage process to find out more, including the support that that innovator or system requires. And as part of this work, we work with innovators to understand the solution and secure partners. And that includes patients and the public to participate in pilots and real-world evaluation studies. We also engage with our health and care systems to understand regional and local priorities to scope opportunity to bridge those solutions. And some of this work falls part as business as usual, but also we have a growing PPIE and evaluation service in Health Innovation Yorkshire and Humber. So please, if you need some authentic, honest broker, patient involvement or evaluation, reach out to us because we can help. So moving on to the 10-year plan, I wanted to highlight to you all today the plan that was published in July 2025, and it really aims to create a new model of care fit for the future. Now, a key theme of the plan is shifting from doing things to patients towards designing services with patients. And that patient voice, lived experience and community engagement are expected to shape how services are designed and improved. So, for example, greater use of the NHS app will require patient education and involvement to ensure that it's fit for purpose for all that's using it. And for innovation, this shift that we see in the 10-year plan is particularly important. We know that many new technologies, pathways and service models fail when they are not designed around real patient needs. So embedding that patient involvement, that patient insight early helps to ensure that innovations are usable, equitable and scalable. So for health innovation networks, this means playing a bridging role, connecting innovators, clinicians and communities, ensuring that that patient insight informs the design and testing of innovations, and using feedback and experience data to support the adoption and spread across the NHS. And a bit later on in the webinar, we'll be talking about a patient insight tool that really helpfully, practically helps you do that. And ultimately, the 10-year plan creates an opportunity to move towards true co-production of innovation and service transformation with patients and the public, something that I think we've needed for quite some time. So moving swiftly on then, I'd like to introduce Annie King-Davies, who is a community project worker and lead for Youth Watch Leeds at Health Watch Leeds. Annie, please tell me that you are there.
Hello, I'm here.
Annie, lovely. You can see the slides okay? You've got your everything you need at your end?
Yeah, I can see the slides. Should I signal when to change slide, or can I change them in this view?
Yeah, Annie, I'm going to pull them across for the whole webinar. So yes, next slide, I'll be there.
Okay, perfect. Thanks so much, Adele, and thanks for the introduction. Really nice to be here. As Adele mentioned, my name is Annie King-Davies. I'm a community project worker and Youth Watch Leads at Health Watch Leeds. Health Watch Leeds listens to people and communities to understand how health and care services are working for them. We're an independent organisation with a specific focus on those at risk of unequal access or experiencing health inequalities. Health Watch Leeds isn't just, well, Health Watch Leeds is Leeds-based, but Health Watch does exist across the country. It's been nice reading the chat box and seeing how far spread everybody is. There is a Health Watch in most areas across England. So have a look in your local area if you haven't connected with them already. They're all doing really amazing work. Health Watch turn what people tell us into recommendations, making health and social care better, fairer and more accessible for people. We do it on the basis that services can't improve without knowing what is or isn't working for people, or what people want to see going forward. Today, I'm going to chat a little bit about how we put people's experiences at the centre of health and care and why that matters to services too. So we know that using just one method to listen means that not everybody can share their voice. So we work with people in a couple of different ways. We visit community groups. We have an advice and information line that people can call, text, email, to give us feedback on services or ask us about how they should navigate the health and care system. We have a programme called Youth Watch, which is a self-led group of 13 to 25-year-olds, and they run their own projects listening to how young people specifically are finding health and care services. We have the People's Voices Partnership, which I'm going to speak to a bit more later. We do a couple of different methods, which I've listed below. One important function of Health Watch is we have representation on health and care decision-making boards and leads. So we have a really important function of bridging that gap between people and community experiences and decision makers in those higher up positions and organisations. Next slide, please. One of the projects that we did recently that I led on is understanding how people found the transition from a single point of access to NHS 111 for mental health crisis. This happened across the country, but we wanted to specifically know how it was affecting people in Leeds. So to do it, we worked really closely with the West Yorkshire Integrated Care Board, Nottingham Community Housing Association, who was commissioned in West Yorkshire specifically to staff the call handling team, and Leeds and York Partnership Foundation Trust, who lead on a lot of the mental health support services in Leeds. And we worked really closely with them to make sure that feedback was fed into their service development programmes in real time, which allowed changes and improvements to be made quickly and effectively based on what people were telling us was going on with the service. We spoke to 371 people about their experience, and they told us really amazing information about what was working really well, what wasn't working, and broader information too about what happens when services change and what's needed to meet people's needs in terms of mental health crisis support. We visited groups and had a survey that went out on our social media, online, and through partners as well. Key findings from the work that we did was 57% of people who didn't use NHS 111 during their crisis didn't know that it was an option. 3 in 5 people who did call didn't find it helpful. Only 1 in 4 people said that they'd definitely use it again. The largest group, 35%, said that they'd only call if they had no other option. Some carers were struggling to get support for their cared for when they were experiencing crisis. There seemed to be a limited understanding of the needs of autistic people in crisis, and call handlers had out-of-date information for signposting in Leeds. And this was really important insight to be getting as this service was set up and running. And because, like I said, we were working really closely with those services, we're able to feed that through and have those improvements actioned really quickly to make sure that the service worked better for the people that were really vulnerable and needed support. I've listed some of the impact here, but this is just some. There's a lot more too, and we keep on actually getting more and more impact as we're still working with those services for improvements now. But so I'll go through some of it now. So we improved the feedback and complaints process. Oh, sorry, could I please just have the last slide, Adele? Thank you.
Sorry.
No, don't worry. Additional training was given to call handlers. There was updated signposting materials for the call handling team. There's process changes that improve people's transition from NHS 111 to onward support. There's improved support for carers. And importantly, learnings from this bit of work have been used to commission future services and for contract changes. Thank you very much, Adele. We'll go to the next one now. Health Watch Leeds chairs the People's Voices Partnership, which is a partnership that works as one team in Leeds to put people's voices at the centre of health and care decision making, with a particular focus on those experiencing the greatest health inequalities. It brings together local leaders in engagement, involvement and research from across Leeds health and care organisations. There's been really amazing work from the PVP, including the Big Leeds chat, where we went out and spoke to people about how they were experiencing health and care in their neighbourhood. Leeds Insight Library for people's experiences and insight to be all held in one central location. a co-production framework used in Leeds, and the 3 C's, which Leeds has adopted as their ways of working, which is communication, compassion, and coordination. The 3 C's was developed in partnership based on what we consistently hear is essential to good services. It has the belief that if we get those 3 things right, we can significantly improve people's experiences, we can save money in services, and we can improve health outcomes. Next slide, please. Thanks, Adele. Another one of our programmes is How Does It Feel for Me?, which follows the experience of people living with multiple health conditions who regularly use different services. It's a part of a wider piece of work understanding how people move throughout the health and care system, and has a couple of different methods of capturing this information. So one of them is following real-time journeys through video updates, which I've got a bit more information on the slide there. It also does case note reviews, understanding citywide complaints, and develops data measures for tracking progress, and is a partnership between health and care organisations in Leeds. This slide has a bit of information about Mercy, who's one of our recent participants, who we follow between October 2023 and May 2024. Mercy has cataracts and dry macular degeneration that severely impacts her sight, and her videos had a really useful insight of when services are inaccessible, when there's unclear information about treatment options, and how for Mercy there's such a vital role of third sector organisations in navigating support. After sharing her videos in with health and care professionals, Mercy received better support, and accessibility improvements benefited other people and services too. So some of the improvements include trusts in Leeds, including her videos in their quality strategy, and improved accessibility features for people with communication needs. Our primary care network added notes and alerts to highlight communication needs on health records. Organisations updated assessments to address gaps and introduced cultural competency training. And Mercy was assigned a dedicated health and wellbeing coach to help her navigate the system. Next slide, please. All local health watch has a statutory power to conduct interim views. So I'll chat a little bit more about this. It's quite unique to health watch and has really amazing impact on improving services. An interim view allows us to visit health and social care services to see them in action, get the views of people using their services as well as their relatives and carers, and to understand how they can be improved. We can visit places where people might not otherwise be heard by services. We've visited some really interesting locations. So in our past visits, we've gone to care homes, disability services, prisons, hospitals, inpatient wards, and more. One of our most recent visits was to a disability service in Leeds, and we really wanted to visit this service because we know that people with learning disabilities who use respite and residential care are often among the least likely to raise concerns directly with providers. And this might be for a number of different reasons. It might be that they don't know how to make a complaint. It might be that complaints or feedback might depend on the staff that they have concerns about, or there might be a fear that speaking up will affect their care. And that's when Health Watch, being an independent organisation, really comes into play. Our visits identified patterns that internal quality monitoring had missed, including concerns about agency staff lacking personalised knowledge of individuals and their care. And it led to these really great improvements to the services, which I've listed here, as well as more that I've not listed here too. So they reviewed the induction processes, strengthened communication with families and carers, and it gave independent evidence to inform their oversight and service quality. And that's everything from us. That's a bit of an overview of everything that we do at Health Watch Leeds. Please, we have more information on our website. Please feel free to have a look at our website. We have full reports and videos and more about what we do there. Or on the slide here, there's contact details about how to get in touch if you have any questions. I'll keep an eye on the chat box too, in case any questions come through as well. Thank you very much for having me. Back to you now, Adele.
Annie, thank you. That was fantastic. Lots of good insight there. We've got the Q&A for all the speakers in a half an hour or so. So we'll see what comes in the chat. We'll see what comes out verbally, and then we can pick that up. But thank you. Thanks so much for your time today.
Thank you very much.
And I've seen Trevor's joined. Are you there, Trevor?
I am indeed. Can you hear me okay?
I can. It's lovely to have you with us today. So you're going to talk about community voices shaping local research priorities. And Trevor, you're from SHARC, and you are a programme manager. And SHARC stands for the Scarborough Coastal Health and Care Research Collaborative. I shall let you take it from here.
Thank you, Adele. Hi everyone, and thank you for letting me come and speak to you today about SHARC. So what I wanted to do is give you a bit of an overview of SHARC, the programme, and then a little bit about the work that we're actually doing around community voices and also community research grants. So the idea for the Scarborough Coastal Health and Care Research Collaborative emerged from Chris Whitty's Chief Medical Officer's report in 2021, which focused specifically on health in coastal communities. The report highlighted how coastal communities like Scarborough, Whitby and Bridlington face unique challenges, so challenges that go beyond individual health conditions and connect deeply to the social determinants of health. These determinants include housing, education, employment and the broader environmental and socio-economic factors that shape people's daily lives. York and Scarborough Teaching Hospitals NHS Foundation Trust are an acute trust, and we cover a large geography with very different populations. The issues faced in our coastal communities are very different to the issues faced in our other locations. And as we have an acute hospital in Scarborough that's located within a coastal setting, which was the focus of Chris Whitty's report, he stated that these areas would be where research would be best actioned, and this proved to be an ideal time to focus research into our local coastal communities. So SHARC was created in response to this report with the aim of bringing health and care research closer to coastal communities and making sure their voices are heard in the process. This would also provide many advantages from a research perspective, such as Scarborough Hospital becoming more research active, enabling it to lead on studies and hopefully increase the number of staff interested in conducting research in the area, building collaboration between primary and secondary care and working closer with our communities. So we're a collaborative initiative. We're co-funded by York and Scarborough Teaching Hospitals NHS Foundation Trust and York St John University. So we have a close relationship with academics as well as clinicians. We cover a 10-mile radius of Whitby, Scarborough and Bridlington, and our borderline is blurred so that we can actually enlarge it and retract it wherever we feel is necessary, depending on what comes through from the communities that we meet with and the issues that they bring up. Our journey began in 2021, and time was taken to build a solid foundation for the programme, which had its official launch in April of 2025. Next slide, please. So our vision is very clear. SHARC aims to better address the health and care needs of coastal populations through high quality collaborative research with community involvement. In other words, research should not just be something done to communities, it should be something that actively involves them from the very start of the process. So often in research, it begins with universities and health organisations, and communities are invited to take part once the ideas and methods have already been decided. So very much a top-down process. SHARC deliberately works in the opposite direction. In line with the NIHR, which is for all global health research, to involve collaboration with communities most affected by the research outcomes. We want to enable those underrepresented and underserved within the areas we cover to have a meaningful voice, both in the research funding process, as well as the design, delivery and dissemination of research. So SHARC has been developed with this ethos at the core of who we are, as our approach and work is led by our communities. So our name, our vision and objectives were developed at an away day with stakeholders, local VCSE groups and members of the community. We worked closely with a project called Sea Change, a VCSE project funded by the National Lottery Community Fund, and we co-funded their community engagement officer. And we hold research events with our local communities to investigate into understanding issues that matters to them, as well as offering introductions to research training for VCSE organisations. We have a community advisory group who are NIHR patients and PPIE public involvement engagement trained, who we meet with every 6 weeks to discuss topics that are important to them, have them review papers and consult with them on areas and potential ideas of research. The group is open for new members to join us at any time, and we are currently in the process of expanding and increasing our membership to cover all the communities we serve. We have a steering group made up of leaders from organisations across the health, academic, VCSE and community spectrum, and have lots of different people involved. We're soon going to start an affiliate scheme for professionals who wish to join our network, which in turn will increase our capacity and research and our reach for research. So I wanted to tell you about a couple of the projects that we're working on. So if we could go to the next slide, please. The first of that being Community Voices. So the Community Voices project we've been working on for a while and is an example of a truly collaborative piece of work. So the idea came as a result of understanding multiple organisations were wanting to speak with community members on various different topics. And community members spoke openly on disengagement with consultations because they were being asked the same questions by multiple organisations and they were never receiving feedback on how their input was being used, and definitely no actions were coming to light from the information that they gave. So we decided to create a collaborative structure across the sectors for having conversations with communities that were designed with organisations and community members. And this is a project that's not owned by Shark. So it's something that we're saying is truly collaborative. We are facilitating the project, but it's very much owned by the organisations within the network and the communities that are involved. So far we've had 3 in-person meetings where we've been designing community voices right from the initial idea through to what the meetings should look like when we do actually go out to the community. And we've had 3 online meetings as well. So the organisation involvement has grown over the time that we've been working on community voices, and Shark is really being the catalyst for bringing these organisations together. And so far we've created a framework that all organisations within the network will work to, and we're now going out to meet with more community members. We have our first meeting tomorrow to actually decide on the session structure, the conversations, and what the feedback should look like. So very much the community members deciding how they would like to be conversed with and how they would like to hear what has actually happened with the information that they have given out. This is creating multiple opportunities for research going forward because we've got the communities expressing what's important to them, and we've also got organisations that are involved that we can really promote collaboration and joined up working with a focus on actions. And that's really what we want to bring to the community, is action-focused results, so they can see that their information is being used in the right way. If we could move to the next slide, please. The next piece of work that I'd like to tell you about are our community research grants. So we're pleased to launch the new community research grants, and it's an initiative in collaboration with the Institute for Health and Care Improvement, and it's to support VCSE organisations across our coastal catchment area. So the community research grants are a grant scheme designed to support true partnerships between SHAR, York St John University researchers and community-led organisations across the VCSE sector. This means voluntary groups, charities, social enterprises, and organisations that are really rooted in their communities. VCSE organisations, as we know, are vibrant, impactful and essential. We also know that they are stretched. We hope the community research grants can support them to evidence the amazing work that they are doing. So the process begins in the community. The VCSE organisations identify issues or themes that are important to them, things that they feel that they need to understand more, or areas of improvement or exploration. They submit these ideas to us, and then for each successful proposal, we match them with a York St John researcher whose expertise aligns with the proposed theme. So this is very much about the matchmaking process. What's important here is that the research doesn't start with the university or with the research department at the trust. It starts with the community. The researcher brings the academic lens and the community brings lived experience and the deep contextual knowledge. And together they co-design the research moving forward. We want to operate inclusively. We want to value the expertise that exists within communities. And VCSE organisations have incredibly rich insights and they see emerging issues early. They understand the root causes and they know what kinds of questions need to be asked, and we want to respect their expertise. Our aim was to make the process as easy as possible. So there's 4 questions that we want them to tell us about their organisation. What would they like help with? How would the research benefit their organisation, and what support may offer to us? As you hopefully have heard from the information that I've gone through with you, our focus is to action research that will best serve to address the health and care needs of the communities we serve on issues identified and raised by the communities, and with the aim to tackle the health inequalities our communities face. Final slide, please. Of course, we have so much more work going on currently, and if you would like to hear more, please feel free to contact me at my email address on there. And thank you again for the opportunity to share some background information on SHARK and also some information on some of the work that we're doing. Thank you.
Trevor, thank you. Perfect timing, perfect presentation. Brilliant to see an approach that's really targeting those underserved communities that suffer those biggest health inequalities. So I really look forward to seeing how this shapes up over the coming years. But thank you so much for your time. We'll save the questions till the end of this slot. And I'd like to now bring in, hopefully she's here, Professor Sally Pearce, Strategic Lead for the Early Years as part of the South Yorkshire Futures Programme and Director of the Early Years at Sheffield Hallam University. And you're going to talk about Meadows Nursery, Sally. Or maybe Sally's not with us.
I am. I'm here.
Oh, lovely.
We're having a few technical issues this lunchtime. Hi, yeah, thanks so much for the invitation and the opportunity to talk to you about the work that we've been engaged in the community of Shirecliffe in Sheffield for the last 5 years. What I'm going to talk through with you briefly is the development of Meadows Nursery, which sits within the Early Years Community Research Centre that was established by the university. And we open with the strapline of changing lives through relationships to really focus on trauma-informed practice and how trust can help to create the conditions for change. Next slide, please. So the background to opening this is obviously not sort of business as usual for a university to open a nursery in an area of significant socioeconomic challenge. And we were actually working with the local primary school who wanted to support families from an earlier stage than when children entered at 3 years. So it was about opening a 2-year provision in a community that had no services for that age group for a decade. And Save the Children were already active in this area as one of their early learning communities. So as part of our civic mission as a university, we were supporting this process when the pandemic hit and the local school were no longer in a position to open the nursery. So at that point, the university stepped in and took on the registration for it. So we opened our doors in the middle of the pandemic in April 2021. Next slide, please. We learned very quickly that this community was facing sort of a wide range of challenges. We've recently done some research that was funded through the Ministry for Housing, Communities and Local Government on multiple insecurities. And one of the communities we worked with was Shirecliffe. It was part of a national study led by the London School of Economics. And we looked at sort of 8 domains of insecurity, of which you won't be surprised to learn that health was one, but it's completely intersects with sort of money, housing, relationships, caring, responsibilities, work, finances, and access to benefits and advice. When we carried out this research in this community, on average, our participants selected 5 of the 8 cards as having an immediate impact in their lives, and that went up to 6 through discussion. So although there are many challenges, what I want to talk about today is that sort of mass really what a vibrant and active community this is, and with some support and with co-design and careful listening, the community is well able to identify the changes they need to make and to make them. Next slide, please. Just to illustrate how these multiple insecurities and inequalities intersect, we actually created some vignettes as a result of the research, which we shared with policymakers across from health to DWP to Department for Education and Housing and Local Government. And the example here of Adam, who is working full-time and permanent nights on minimum wage as a security guard. He lives in a 3rd-bedroom maisonette with his wife and 2 children under the age of 5. So sharing a bedroom, which is constantly, everybody's sleep is interrupted by the different working pattern and education, and there's never enough money to go around. To compound this, Adam has diabetes and high blood pressure, both of which are exacerbated by having to work permanent nights, and there's a lack of feeling of sort of safety in the local area. So this really helps us understand sort of how, you know, sort of those multiple insecurities come together, as well as what helps in terms of really hyper-local support, the opportunities to train, opportunities for childcare and for social connection. Next slide, please. So in the face of these challenges and working alongside Save the Children, we opened the nursery, say with the strapline of changing lives through relationships, and with staff that were trained in trauma-informed practice. But it very quickly became apparent that we needed to meet the most immediate needs that families were facing if we were going to sort of engage and support them. So over the last few years, we've sort of introduced a variety of ways in which we offer that support, from really getting to know families before they come in, through home visits, through meeting their immediate need, whether that be not having a suitable sleeping space for their child, or a car seat, or families that lack access to a washing machine, to supporting around food poverty. And the Save the Children have really been key, that partnership, in helping us to meet those needs. Sort of spinning out from that, with a high proportion of children who are awaiting diagnosis for special educational needs. So we set up the Dandelion Group, which is a peer support group for parents to come together while they go through that process, and to provide practical strategies and access to services who come in to talk to them, to support them throughout that journey. One of the things that we do within the nursery is relationship mapping. So we try and ensure that every child and every family has a close connection with one of the members of staff, and we actually actively map those relationships 3 times a year to ensure that happens. As our trust and relationships are built, we've gone on to provide training courses for parents and community events and trips. Next slide, please. And this preventative approach has really created interest and other partnerships. We're now funded through Homewards, from the Royal Foundation and the Viva, to have a family link worker to really walk alongside families, going, whether that's accessing health services, whether that's accessing housing advice, or to any other immediate need. And as our families' confidence have grown, they've really become advocates for themselves on the changes they want to see. And you may have seen the panorama, Britain's Child Health Crisis. That was actually filmed here at the nursery with our parents, who wanted the voice of their lived experience to reach policymakers. Next slide, please. So one of the key tools in sort of engaging with families and supporting them has been around co-design, using a double diamond approach of really unpicking the most immediate challenges with families, defining what the problem is, developing a solution, delivering a potential solution, delivering that, and then reviewing. When we started this, which is over 4 years ago now, what families said they really wanted was a breakfast club, but not for children, for adults, somewhere where they could come, build social connection, have a hot meal. They were often feeding themselves, but feeding their children, but not themselves. So it was a space where they knew they were going to get a hot meal. And then they wanted other services to come in and meet them there where they were at, in a trusted space. So the parents are completely involved in the co-design. It was supposed to run for 4 weeks as a trial. It's still running 4 years later. And now it's completely run by the parents themselves, and has led to many other things, as I will now describe. So if we could go on to the next slide. When we've sort of reviewed with parents sort of what makes a difference here, a lot of it, as in the Maya Angelou, it's how people make you feel rather than what you do. So it's about that authentic, trusting relationships, being warm and welcoming. It's always the right door to walk through. We start from the stance that it's what's happened to you and not what's wrong with you. And as you can see from the feedback here, some of the most powerful, knowing that you can cope when you feel like you're a good mum. Next slide, please. So our families, and it is, I will say, it's not exclusively, but often it's the mothers, who, because they are the people who most often come into nursery, have started to realise their own sort of ambitions and aspirations. They've gone on to a number of training courses, one of which is called Knowledge to Nurture. It's not a parenting programme, it's about identifying your own needs to then be able to support your children. And our parents have gone on from being on the course to actually training as trainers and delivering that. And also going through the introduction to community development and health, so they're gaining the skills to make other changes. Next slide, please. And what that's led to is a community interest company that was established in 2024 by some of those parents who are now going through co-design with other parents and have opened up another community building that had stood empty since the pandemic. They now run a weekly food pantry from there, and as a last count last week, we have 53 families who now come every week to address their food needs. They've managed to secure funding for sports equipment and exercise equipment to run health activities, and are hoping to open up across the school holidays because of that need to support other families. Next slide, please. And I've put this in because one of the things that families taught us has been most important is creating community memories and connections. So we run quite large events. We take the families camping every summer. So up to 60 families going camping, experience the outdoors, many of whom have never done that before. The Christmas Eve sleepover for families, Halloween parties, trips to the seaside, things that we might take for, maybe taken for granted, that you have those experiences, and when you come together with your family, you talk about them. But the families in Shirecliffe wanted that for themselves, and that's been one of our key deliveries over the last 5 years. And that's everything, unless there's any questions.
Going to have questions at the end, Sally. That was fantastic. Such heartwarming stories there, and you can really see the impact of these programs and the tangible impact that it's having on families and young people. Brilliant. Thank you so much. I'm going to introduce Scott Cunningham now. So Scott Cunningham is Patient Care and Public Involvement Manager at Leeds Teaching Hospitals NHS Trust, and he's going to talk to us today around strategic decision making and service design listening events. Scott, are you there?
I am, yeah, and slightly unnerved that I have to follow that amazing presentations or the two previous presentations, but I'll do my best. So hello everybody, my name is Scott Cunningham. I am, as said, the Patient Care and Public Involvement Manager at Leeds Teaching Hospitals Trust. There is essentially me who is responsible for delivering our patient care and public involvement strategy, which in a nutshell, one centres around supporting people, and I would suggest ordinary people, not necessarily a kind of non-paid professional opinion, but the folk of Leeds, to direct the kind of strategic direction of the trust and support the development of strategies. Within that, there's a lot of stuff around using what we already know. We use the 3 C's as already mentioned, so we use a lot of the insight library. Our second aim within our strategy is, so there are 22,000 members of staff where I work, and I can't be everywhere. So we deliver an annual program of training and development. So we run what's called head-to-head sessions, which are kind of mentoring, support to people developing and designing engagement activity. We also have a program of what we call learning bursts. So on Thursday, I think we're delivering one called More Than Words, which is about how you engage people where capacity might be a challenge and who may communicate who might not communicate verbally. And our final aim centres around health inequalities. However, I'll talk a little bit later about something called community connectors. So I feel my presentation is going to be a little bit pedestrian, but I'll try and make it exciting. So I'm going to talk about, much of my work sits under what's called working in partnership with people and communities, which is the statutory guidance around involving people and communities. And more recently, something is called out come out called the Experience of Care Framework, which I'm going to have to get my head round. So as a team, a lot of my work is actually dictated by law. And I spend a lot of time with our corporate planning team, etc., who will approach me and say, we've just received some money. We're just about to rebuild a section of Chapel Allerton Hospital. You need to go out and find out what folk think. So at that point, I have to think about the law, and it's not on there, but I believe it is still Section 242B of the Health and Social Care Act refresh, if you're that interested. And a bit in that law says I have to design some engagement activity which is proportionate, but the term proportionate is still a bit woolly, hence the sheep. So in Leeds, we're quite lucky, as other areas are. If you could just do the next slide, that when I get presented with supporting a piece of work, I have to make an assessment for the level of change that's occurring. So this isn't a legal document, but it's a useful criteria for me to kind of decide what needs to happen when, how do I sit it in with the governance arrangements surrounding a project or programme. So I'll talk a little bit about the walk-in centre, which is in Bermontoffs in Leeds, which is #1 for the highest level of deprivation. If you could just go a slide up, that'd be great.
This one?
Just to keep back, sorry.
Oh. Yeah.
That's the one, yeah. So there's basically levels 2, 1, 2 and 3, and there is 4. That's where we get into formal guidance. And it rarely occurs. That's when we start talking to gateways. We have to take stuff through gateways via NHS England, etc. So most of my work centres around 1, 2 and 3. So this was a walk-in centre. They were looking to provide patients with the ability to call the 1-1 service and book an appointment rather than just the ability to walk in, but also they were extending the offer of care and treatment and to offer some treatment which might have traditionally been held within the A&E section. So walking through it, looking at the evidence that I already had, we decided that there is good evidence that this would be an improvement, an enhancement to the current service provision. It was only a small to medium scale change, but was a new service. And as you can see here, I also thought, well, actually, there was where it is, despite the rhetoric around it being a poor community, it's actually incredibly active. There are lots of local folk doing great stuff. They were in touch with the elected members, etc. So we had to be mindful of that. And we always would be, but specifically and very mindful of those folk and that we had to work alongside them. So we did this work over about 3 months. So when I've assessed the level of change, the other thing I need to do, which is on the next slide, is I have to complete an equality and health inequality impact assessment. Thank you, Adele. So this is a very small portion of that assessment. So it lists all the people who are covered under the single equality duty, all those people within those 9 protected characteristics, but it also includes those people within Core 20+5, the NHS framework for health inequalities. So we already know that Bermontoffs is the place in Leeds that has the highest levels of deprivation. We also knew that the walk-in centre was or is a place that's used by a lot of homeless people because there's a St Anne's recovery centre down the road and lots of people get their mail delivered there. A lot of asylum seekers, a lot of refugees, so language may not be their first, English might not be their first language. So I have to take these things into consideration, not just for the people who are going to ultimately deliver the service, but in terms of how I conduct my engagement. So when we were first talking about it, the commissioners were talking about, well, you need to set up a panel and you need to have a working group and all the rest of it. And that's great. And it's really good. And we did have a patient group. But if we can just go to the next slide. If we recognise that for the most part, the people accessing that current service and the new one, attending a meeting or attending a workshop is not the first thing on their mind. For many of those people, it's about finding a place, excuse me, it's about finding a place to sleep for the night. It's about being able to pay the rent, not feeling comfortable around lots of folk like me who look very professional. So ultimately, like previously mentioned, we went to them because it's the way forward. So if we just go to the next slide. So, as I mentioned earlier, the first thing we always do, what people tell us, is they get really annoyed when we ask them the same things over and over again. So we access our insight library within Leeds and look for stuff that might be helpful in terms of what people have already said. We also have an LTHT insight library, so I access that to look at what people have already told us, and that would inform the decisions made towards the end. If we could just go to the next slide. We classically ran an electronic survey of 35 people, but we also went there and we spent 2 weeks sat with people using the survey, but not necessarily like a survey. We didn't want a pedestrian response. We wanted to have a conversation with people. And because there were a lot of people whose first language wasn't English, who with low literacy levels, etc., I produced some easier to read information. We also use ReachDeck, which takes that information and translates it into about 212 different languages, I think, from across Leeds. But importantly, that exercise is built into people's days, because if you're having to get home to pick the kids up and all the rest of it, then you might not have time to come to a workshop. But what we also did is we do have a patient reference group within the trust, and what they provide for us is, so we've done some training with them, they do some independent analysis of the qualitative data that we're presented with them with. So that's just a kind of example of the kind of big change stuff that I might do. If we can just go to the next slide. What I'm always interested in is this stuff. So I've already mentioned that my job is about capturing the lived experience of people. So if you look at the comments in the orange slide and the comments in the blue slide, they're very, very different. So in the orange slide, I would suggest that most of my colleagues would make comments like that. But the comments on the blue side, I would suggest read more like patients. The truth is they're both from patients, but one is gathered through the electronic survey, i.e. the orange, and the blue is conducted through listening events. So we get a much more authentic feedback and insight. And have I got time to do 2 more slides?
Very quickly, you do. Go for it.
Yeah. So next slide. We also do something called community connectors, which is where we recruit people from what we're now called inclusion health groups. And they work alongside us because they have existing trusting relationships in what are more often than not called third places, if you're into the whole ABCD world. So our first community connector was a lady called Judith, who was a member of the recovery community of Leeds. Judith had been sober for about 30 years. So there's a phrase that says we're more than our job title and more than our health condition. I happen to be part of the recovery community of Leeds, so I was able to recruit Judith. She now supports our drug and alcohol steering group and our relationship with AA and NA. So that's where the true co-production comes in. So it's not necessarily about Judith having an opinion on services. It's about recognising that services do some things really, really well, but actually people and communities do other stuff much better. So that is an overview of some of the stuff that we do, and I'm sorry for racing through and going 1 minute 31 seconds over time. I'm super sorry.
No, don't apologise. It was really good. I found that particularly helpful because we talk about the working with people and communities guidance that NHSE published, I don't know, 2022, I think now. But it's great to see how it's actually worked up in practice and how, you know, what it means adhering to that in practice. And also great to see reference to the Insight Library. We know that patients and the public are often asked questions multiple times. So to draw in and tap into that previously given information, super helpful. Thank you so much, Adam. I think I'm going to hand over to you to facilitate the Q&A if we've got any.
Hey Adele, I think I've just seen one question that's come in so far. what do you see the threats and opportunities with the anticipated loss of Healthwatch, specifically the independence of local health watchers, including the ability to engage with people not utilising the health and care services?
I mean, I can think of a few myself, but Annie, I wondered, with your Healthwatch Leeds hat on, what are your reflections on that question?
Yeah, I can answer this question, but also welcome other reflections as well from other presenters. There's a really amazing piece of work that the King's Trust has done recently that might be of interest, and I'll put it in the chat box afterwards. That's around learnings from a Healthwatch model for whatever comes next. One thing as well that I think you have alluded to in your question is independence for Healthwatch is a really important feature, and it allows Healthwatch to really speak truth to power because we're not affiliated to any particular service. It also allows much more trust in communities, like you say, particularly people that aren't already engaging with services because of a historic mistrust or because they don't think service will listen to them. I think that from a Healthwatch Leeds perspective, we have concerns about what the alternative will be if Healthwatch doesn't exist as an independent voice mechanism. And we know that services are really stretched at the moment, funding's really tight. And as Scott's just mentioned, there's so much the information that you can get for people of how they're finding services can be really rich with careful listening and co-production and really going into communities and meeting them there. There was a suggestion that the NHS app will be a place to gather feedback and have that independent, that people's voices there. And we know from work that we've done that apps and online surveys don't work for many people, particularly people that are likely to face greatest health inequalities. We know that Healthwatch provides a lot of accountability, and there is a big risk if Healthwatch ceases to exist. In Leeds, we've got a lot of support from senior leaders that an independent voice organisation independent voice mechanism will continue to exist. And we hope that if it's not Healthwatch, whatever steps into that space will continue with any learnings that we've already discovered in the Healthwatch model.
I think it's too early to know what that future model looks like, but if we think back to Scott's presentation, where we talk about the NHS app being a mechanism, you could see the stark difference in what was said in those orange boxes and what came out of a conversation. And I do worry that some of that will be lost. So we need to keep a close eye on that new emerging model. Any other reflections from speakers on that particular question? Come in, Scott.
I was just going to say, I think it's important to remember that there's something about arming people with the knowledge of the legal duties that public sector providers have, and the fact that everywhere is losing staff, etc., particularly in our world. I don't want, you don't get into a kind of we're worse off than you, but actually without health watches, who's going to do it? I've already said I'm one person in 22,000 members of staff. We've got a great relationship with Healthwatch Leeds. They offer something that's fabulous. So maybe there's something about how Healthwatch sell themselves, and I don't want to teach. There's a phrase about grandmothers and eggs, isn't there? There's something about how they reinvent themselves to fill that gap where lots of organisations are going to struggle because they're too busy delivering the service, if that makes sense. Yeah, that would be my thought.
I agree. Thank you, Scott. Ian, I saw your hand pop up for a question, but we are running now 3 minutes over, or a couple of minutes over. So what I'm going to do is suggest that we move on with our internal Health Innovation Yorkshire and Humber presentations, and then whatever questions we can't capture and fulfill today, we will provide that document. So I'd love to introduce now, let me just move the slides on, Yara, who leads our Well-Mind Health, Be Mindful digital workplace programme. This was a piece of work that we secured a commission with last year. Yara, come in. And I think we've got a public contributor as well supporting you today, don't we? Linda Cole. Welcome, Linda. lovely to have the patient voice.
Exactly. Thank you so much, Adele. You can move to the next slide, please.
Thank you. There we go.
Yes. So yeah, Be Mindful is a really meaningful initiative. You can move to the next slide, please.
Sorry. There you go.
Yeah, and this initiative helped me to grow a lot, so I'm really thankful. So to set the scene, disabled people, they are not managing their physical conditions, but also can impact significantly the mental health. So especially in workplace or when looking for a job, there are testimonials of people fear of disclosing their conditions, fear of asking for reasonable adjustments, or they can even mask their conditions. And just with the fear of facing stigma. So it's really challenging, and it can increase stress, anxiety, and loss of confidence. So the work we've done builds on the SBRI initiative. It stands for Small Business Research Initiative to provide practical support. Be Mindful, it's an existing mindfulness program. It helps to reduce stress, anxiety, and improve confidence. Our role with the developers from WellMind Health was to improve this program to make it accessible, relevant, and meaningful to these individuals. So the core of the work was to co-design the program with people with lived experience. Next slide, please. So it was a collaborative effort. So us from Health Innovation Yorkshire and Humber, we led 8 co-design sessions with 11 members, drawing from their lived experience. So we call them a public advisory group. Even Break is a partner. They led the inclusive recruitment process, very successful. And also WellMind Health is the organization that owns the platform, so they would adapt the platform according to these insights coming from this amazing group. Next slide, please. As a result, this program now, it provides alternatives to body-focused exercises, because many of these individuals, they said that mindfulness, sometimes they focus too much on body parts, so it could feel uncomfortable at times. So now we have alternative exercises. There are clear options to skip, pause it, and return later. They would be aware of emotionally intense content prior to accepting to watch. What else? Accessibility features, British Sign Language, easy read formats, playback controls. In other words, they can customize the experience to suit their individual needs. Now I'll give you the opportunity to meet Linda Cole. It's an inspiring public member who was part of this amazing initiative. Welcome, Linda.
Hello. Next slide, please. I just want to start by saying something a little unusual before I go on to introduce myself. I'd like you to imagine slides you can't see in this presentation, words that perhaps you can't clearly hear, in language maybe you don't understand, and then perhaps having to find a family member or a friend you trust to advocate for you and translate, with no real guarantee of success. This is a lived experience of most disabled, neurodivergent and chronically ill patients who are all lumped together into the package of the disabled. Next slide, please. So disabled is the one group that any one of us in this presentation could join at any time. 1 in 4 people of working age are disabled. As a former employment specialist, I've heard people say to me, we don't have any disabled people in my team. That's not always true, because research by Bupa has shown that 40% of people with unseen disabilities don't disclose their disability.
I think Linda might have frozen.
Yes, turning my camera off just in case of. One moment.
Just give her a second, it's fine. You still there,
Yeah.
Linda?
I'll ask her to come back.
Thank you.
Yeah, I think she left now. She might be coming in a moment.
Yeah, let's give her a minute. I mean, I've got the slides and I could talk to it, but I don't think I could do it justice as Linda did.
Yeah,
Very
I feel the same.
powerful.
I feel the same.
Yeah. It wouldn't be a webinar if there wasn't some kind of technical hitch.
Yes, I think we just achieved the one tick on the box for a webinar.
Yeah. Apologies to everyone still with us. Just bear with us a second. Yara, you've done your bits. I'm just thinking as
Yes.
yeah, okay. I wonder, given it's 2:05, if we jump to Graham and then when Linda is able to join, we pick this back up, Yara.
Get I'm sure she will be happy with it. I'll just text her.
Let's be innovative and move it around a little bit. So I'm now going to introduce, I'll just get through these. Graham Presswich, our patient and public involvement lead, who leads an ongoing commission that we've got with the National Pathology Imaging Cooperative. Graham, are you there?
Indeed, I am. Thank you.
Thank you. Over to you, Graham. Let me know when you need me to move on.
Next slide, please.
Okay.
Good afternoon, everyone. A little reminder of how we're making progress from sitting at a microscope, trying to understand what's happened to someone through a traditional glass slide, moving to a digital method for looking, comparing and viewing illness, the cancers and so forth that people are suffering from. A big change for the pathology profession. And I'd like to share with you for a couple of minutes how a group of members of the public have helped to shape that change over the last few years, centred in Leeds. Next slide, please. The programme had a number of objectives, which is about transforming pathology from a glass slide and an optical microscope to a digital system, to then disseminate that best practice across what is now becoming the country and perhaps globally, and then be able to introduce and evaluate AI tools to be able to speed up and improve that process at a time when the number of pathologists queuing up to join the profession is diminishing. And then it creates, through that, a fantastic platform for research and innovation. That's what we're at. And to help us along the way, next slide, please. We had a lovely group of people who have been involved right from the start, our patient advisory group. Very importantly, this group meets regularly with the leadership team of NPIC. We meet informally, together, we chat, we work through NPIC's programme of development and share in those conversations with the leadership team. And it's that ongoing sharing and involvement that is key to the importance and success of helping people shape and inform a very technical approach to improving care. Next slide, please. We've been helped by publishing the work that we've done, and it's enabled the credibility of the group and the credibility of NPIC to be, I think, vastly increased by being able to show that the public have helped inform and shape, and through that build trust and confidence. And with all these things digital, building trust and confidence for communities that we've been hearing about, particularly from Scott and others, it's that trust and confidence in what's going on around us as patients that matters so much. Indeed, in the next slide, please, we've reached out to the pathology, the Royal College of Pathology, and helped them and help pathologists understand that involving patients directly in their work is a valuable and worthwhile thing to do. Next slide, please. So the pathology team at Leeds see that the involvement and the group that's helped them shape, when I say helped, I think we're on up to 26 meetings now, being involved and shaping what goes on over several years. But it's that is key to making this a successful programme, according to the leadership team. The voices of patients ringing in their ears as they go and seek further deployment opportunities. The views that patients have helped shape the systems and processes that are behind this has been absolutely vital. And I take my hat off to every member of the group for all their contributions, support and help. Next slide, please. So the difference we're making is perhaps easiest described as 3 more trusts in London joining the pathology, the NPIG family. And if you can imagine how many millions of people lives are going to be changed perhaps at some point by having the speed, accuracy and benefit of a digital approach to their pathology, then you get a feel for how big and important this work is in improving people's lives. Thank you.
Graham, thank you so much. I love the work that we do with NPIC and the difference that that involvement group is making to the work of NPIC. So thank you very much. Linda, are you back in the room?
I'm back in the room. Virgin Broadband sadly let me down at the wrong moment. So I will continue if that's okay when people are ready. Okay.
Yeah.
I was just saying that, you know, there are huge numbers of disabled people in this country. 1 in 4 people of working age being disabled, whether that's deaf people, people with long-term conditions like long COVID, or people in wheelchairs. There are so many types of disability. There'll be people with disabilities in every workplace. Next slide, please. I just want to start by introducing myself, which seems particularly appropriate now since I've ended up restarting, almost like I planned it this way. I'm a mum of 3 children, and I've got lived experiences of visible and invisible disabilities or long-term conditions. I'm a former IPS employment specialist. I've helped people with severe and enduring mental illnesses find and retain work, or perhaps retain their job when they thought they were going to lose it because of their mental ill health. I joined the PAG, the Patient Advisory Group, to make the programme more accessible for disabled people. And I'm really excited to be able to tell people in Yorkshire about how it's worked out as a proud Yorkshire lass, but living down south. What does the co-production look like? It was a really friendly group. We met on a lunchtime online and we talked through our experiences, which were emailed to us a few days before, with questions like the ones you can see on screen at the moment about our experience of using technologies with features that made it easy to access or difficult to access. We talked about any experience of mindfulness, which led to some of the changes that Yara's mentioned already. And we talked about the barriers that we know that people who are disabled encounter in work, whether that's attitudes or transport or working practices, flexible working or reasonable adjustments. And we also did some creative work around things like talking about your dream supportive workplace. And I think by having a mixture of the good experience, the negative experience people have had, and the hopes for the future, we were able to make sure the changes that Yara and her team put forward to the developers made the app stronger and more inclusive to disabled people who will use the app as they prepare to return to work. Next slide, please. Personally, I got a huge amount out of being part of this project. To me, it felt like an opportunity to make something good come out of the bad experience of suddenly finding myself disabled with 3 kids in my mid-40s. And then there was a fuzzy feeling of feeling like I've made a difference. And actually having one thing the PAG did particularly well is they emailed us afterwards and said, these are the things we changed as a result of your feedback. And they gave us a chance to try be mindful and see the difference we'd made. And I feel incredibly proud to have been part of the project. It also really helped me to understand more about the difficulties other disabled people face. I know the disabled isn't a heterogeneous group. We're all individuals first and then disabled people after. 2 people with the same condition might experience that condition really differently rather. I learned a huge amount from the facilitator, Yara, and I've actually recently taken on what I've learned from Yara and gone on to facilitate a focus group for a charity, Disability Equals Ability, myself. And I'm actively looking for other opportunities to work as an expert by experience and as a research professional within this sector. Next slide, please. So that's enough about the difference it made to me as somebody who was involved in the PAG. But I want to take a moment to think about what the takeaways might be for your team. As I said at the beginning of my presentation, before the internet went down on me, any one of us could find ourselves disabled at any time. I'd also advise always working with people with lived experience. Don't research on us, research with us or work with us. And it's been great today to see so many other people from across the NHS and beyond passionate about working with lived experience to make services fit the needs of the communities you serve. Treating people as individuals makes such a difference. When people feel they're heard in their care experience, they really do benefit from that. Let people participate in different ways. We saw in orange and blue on somebody else's slide just earlier how different feedback can be in person to by email. Let people participate on camera, off camera, through voice, through chat. Inclusion can be really cost effective. Can you afford to exclude 1 in 4 of your employees, 1 in 4 of your patients or your customers? That's 1 in 4 people of working age. Bearing in mind as we reach retirement, sadly our bodies do tend to pick up more long-term conditions, more injuries and more illnesses. So working with an aging population, inclusion is going to become more relevant, not less relevant. And I want to close this by saying that inclusion will increase your team's impact, whether that's in terms of improving the well-being of your patients, whether it's in terms of making sure a service fits people's needs, or whether it's about reducing DNAs. It will help you. Thank you for listening.
Linda, thank you for a very powerful and quite hard-hitting presentation at times with those stats. And I think to hear how you've worked with the Wellmind group to really, enhance the development of that programme, this is what I love about this job. It's when we hear the impact that patients and the public have made. It's super powerful. Thank you so much for giving us your time today. Really appreciate it.
It's a real pleasure to be here and hear the amount of passion in the room for improving things for all of our care for the future. My apologies for
May it
virtual
continue.
broadband.
Thank you. You came back. Brilliant. Okay, I'm going to move us along speedily back to Graham, who is going to talk to us about some work that we did to develop a patient insight framework. Graham, back over to you.
Adele, thank you very much. In the interests of time, ladies and gentlemen, I'm going to be extremely brief with this presentation, and the slides are available afterwards for you to be able to follow up and pick up on any elements of it. I'm just going to give you an introduction, and then you can pick it up and have a look, and please come back to us. This is not patient-centred care as we would like to see it, but it's how often, so often it is delivered. Putting the patient at the centre, as Linda has already talked about so elegantly, it's about working with patients, not just putting us at the centre. And this framework was put together with patients informing and guiding it to be able to improve on that situation hugely. Next slide, please. We bring value. We don't always agree with what other professionals say, but it's not because we're wrong. We have a real lived experience, which means that we see the same thing differently. And it's that difference that is the value. That difference makes a huge difference to getting it right. And as we've already heard, if you get it right, you'll be far more successful. So the bottom line is, by involving people, your success is much more likely and going to be much greater and much more satisfying if you include us. The framework, next slide please, was put together to respect the fact that for the vast majority of time we are in charge. We do most of the donkey work, the heavy lifting when it comes to health and care. We do tap into a little bit of support now and again, but we have most of it to do. So why not come to us and see how we can help, particularly around things like the introduction of innovation. And that's what we did. We asked people. Next slide, please. And medicines are a great example of all the jobs that we have. Next slide, please.
Yep.
And there's lots of evidence being published for many years about helping people to be involved makes such a difference. The evidence base is there, and yet the amount of involvement, as Linda's described, is still pitifully small compared with the difference that we could make if we were genuinely included and involved. Next slide. So we went out and asked people at the behest of NHS England and responding to the poor uptake of nice guidelines and nice innovations, nice supported innovations, to be able to improve the uptake and the benefits to more people. Next slide, please. And we followed a pathway that is the framework, understanding what matters most to patients and importantly their carers, who can respond to those needs, and then putting those into a plan. Next slide, please. But to follow that, we didn't take a system-based approach. We took the patient's approach. We walked in the patient's shoes from the armchair in their lounge at home, right the way through to re-entering their home, improved, helped, feeling much better, having things sorted out, and a prospect of a long and much more healthy life ahead of them, sorted out by working with the patient through their journey. So we unpacked that journey, asked patients about what was going on, what mattered most to them, and that's how we discovered three big themes that came out. Next slide, please. Next slide again. And those themes were really about how to support people properly. And if I may say again, Linda, you cracked it all. It's that support that you talked about to be able to access that appropriately is so important. Communication and understanding of information, and then understanding the impact. What difference is an innovation making to someone, and be able to feed that back so that we can help to build on that success. Next slide. So the framework is in 4 stages. You can read about that from our website. Next slide. And the details of what you can expect at a stage is also described in some detail. Next slide, please. So for those 3 big headings, what we've helped to describe is the different tasks, the different responsibilities, patients, carers, suppliers, providers and commissioners can take to be able to develop a whole system picture. And where you sit in those different stakeholder groups enables you to play your part in helping me as a patient and others, all those other patients, be able to make the progress they so rightly deserve. Next slide. And the same again, please. So we're back to the summary of what it is, matching my needs to who can take action and producing a single plan. That's what the framework is about, enabling anyone involved in the introduction of new ways of working, innovations in processes, to be able to improve that through a single plan, but all the stakeholders involved. And that's the framework approach. Thank you. Next slide talks about some high impact actions that you can take, and we're out of time. Thanks.
Thanks, Graham. Again, that was a great piece of work that we did, and it continues to be used. And now this segues us lovely into hearing from Adam Smith, our MedTech Adoption Project Manager. Adam also supports PPIE. Adam is using the framework to help the spread and adoption of a MedTech funding mandate product, APOS Health. Adam, over to you.
Thanks, Adele. Thanks for the introduction, because you saved me a few seconds there as well. So as Adele mentioned, I see things from two sides really. So I've had my previous few years experience, I've been leading on this adoption spread program of health innovations, NICE approved health innovations, and more recently joining the patient involvement team. So I tried to bridge the two really, kind of seeing where real experience, lived experience, needs, expectations have not interwoven into adoption plans, and it can be at detriment of innovations not seeing the impact for patients, for the system. We kind of missed that opportunity because we've kind of not done that and set that up, you know, as Trevor mentioned before in Shark, like kind of set that foundation early on to then grow from there. So as Adele mentioned, I've been using the framework. This will kind of retrospectively, so we did it with the APOS shoes, which you can see on screen now. NICE approved trainers that patients wear at home to relieve pain from knee osteoarthritis. So we wanted to learn more around these trainers, predominantly, yes, lived experience around knee osteoarthritis, what's that's like to live with, as well as the kind of the question that we had that wasn't answered through NHS data or widely through literature, why people would not want a total knee replacement surgery, as these were seen as an alternative. So the steps through the framework that Graham just had to fly through, I can just talk a bit about what we did in that space. I think Scott mentioned before, kind of starting that, you know, what do we know now process, desktop reviews, looking at patient insight that's out there, looking at these resources, these insight libraries that are out there to understand it. As I said before, quite a lot around the osteoarthritis versus arthritis, the leading charity community that had a wealth of information around what it was like to live with knee osteoarthritis. Less so some of these newer alternative innovations like APOS that were out there. We want to know about how patients navigate those MSK pathways, really complex pathways spanning across primary, community and secondary care. And part of the process that the framework is a must in step 2 is looking to emotionally map that pathway. Where those themes, the 3 themes that Graham touched on, really sit with it. How are patients supported at different parts of the pathway, going into the pathway, after the pathway, during at those different points. Communication, massively important. What's provided to patients, during that time. And then the impact of the innovation. Sometimes it's not obvious that an impact is felt immediately. Is it going to be felt later? But managing those expectations around that. Next slide, please. So aligning stakeholder responsibilities is tricky, and it's very difficult, and it's been great to see so many people and such varied roles attending this, and that investment to kind of want to succeed and improve in this space. Again, MSK with this pathway, many different stakeholders stretching all across that pathway in different areas of care. It was quite difficult to actually understand where APOS sits within a pathway, but through our involvement and speaking with patients with lived experience, it were kind of pushing it further and further towards that front end of the pathway, and that's where we were able to then engage stakeholders and really understand what their responsibilities are within that pathway, and what the expectations are of patients. How are they meeting that needs within that, and how that can be communicated. Okay. So in terms of, next slide please, so in terms of translating that into an action plan, so after we'd done that activity, we interviewed patients, we engaged with patients, we had those ongoing stakeholder conversations. We felt it were time, June last year, to get everybody into a room. So we were fortunate, we're not talking about one acute trust here, we're talking about several across Yorkshire. We were able to get them in the room with patients who were involved in our engagement. They were also in there, the trust representatives, APOS themselves, MSK stakeholders, supply chain, and we really reviewed the insights. We discussed implementations for the pathway. What are the barriers for bringing this in? What are the sat on a backdrop of the patient priorities in what that looks like? The need for that earlier in the pathway. So we were actually looking at bringing it into orthotics after exercises and other methods of managing that pain have been kind of tried and exhausted in some instances. Instead of moving through the pathway, looking at APOS as an alternative to allow patients to comfortably manage the pain in the confines of their own home. So this were really used as an example of not just taking what patients are saying and how they feel about it, but actually turning it. The framework allows you to turn that into action, plan that action, plan what that planning, implementation, and indeed evaluation looks like at the end of this. We'll send some more information after this. Yeah, I know we're tight for time. Back to you, Adele, quickly. Thank you.
Thank you. I'm conscious we are completely out of time. Huge thank you to the 50 of you that have stayed on till the end. We don't have time for Q&A, but we will answer your questions. If you've got them, send them in. We will formalise a Q&A document. I can't see the chat. I can't see what's been added, but a huge thank you to all of you, and have a good rest of the day. Thanks to all of the presenters. Thank you. Take care.